We're really thankful to Eli and the World Parkinson's Coalition for providing a platform for us to share resources and think and work together as a global community. India and Kenya, both developing countries, have comparable challenges. This case study aims to explore if the strategies we developed to deliver a community-based, multidisciplinary model of care through a network of urban, rural, and tribal support centers across our country could be replicated in Kenya. Today, we will discuss the factors that have contributed to the successful implementation of the program in India, the key contributor being building on the available strengths and resources of the community.
Maria, when you say community-based, what does this mean and why was it so important for the model in India?
By community-based, what I mean is the importance of conducting the support group at a venue within the community. This could be a school hall, spaces provided by temples, churches, or a community hall used for social occasions. Utilizing a community space has multiple advantages. Firstly, it's easily accessible. It's taking the program to the people. And most members who attended reported an experience of well-being, as it was not a clinic or hospital where they were being treated for a neurological condition.
Maria, given the fact that we have limited allied health professionals in Kenya, how were you able to run these centers since you face similar challenges in India?
I think this factor is common to all developing countries. And the strategy we used was to identify, train, and employ facilitators from the community. These were from varied backgrounds, ranging from healthcare professionals, carers of people with Parkinson's, individuals involved in other community-based healthcare programs, or those who had an interest in being trained with a view to employment. The challenge here was assessing their level of competence, skills, knowledge, and then developing training models for each category. As we initiated each new center with a different category of facilitator, we developed training models to meet their needs.
You mentioned that you had urban, rural, and tribal settings. So how did these different models fit the different contexts?
Well, we had to contextualize the content and the implementation based on the setting. This involved translating and adapting to the socio-economic differences, cultural norms, and religious sentiments. This was really a crucial factor that ensured engagement and sustained interest in the program.
So, what did your support group members find most effective in the content of the sessions?
Well, what we learned from our initial work was the importance of focusing on the practical implications of the session content. Most members reported that relating the education and therapy to the direct impact on the quality of life resulted in greater participation and compliance. For example, exercises that were part of the physiotherapy intervention focused on activities of daily living, thus increasing the level of independence. The speech therapy improved the ability to communicate, participate in family discussions, and thereby reduced social isolation. As most of our members were unaware of the non-motor symptoms, explaining the kind of cognitive challenges they were experiencing or might experience, and providing simple techniques to overcome them resulted in a better understanding of Parkinson's.
Was the involvement of caregivers and family members important too in these sessions? And how did you achieve that, Maria?
Well, in our evaluation of the effectiveness of the model, one of the key factors that emerged was the level of integration of the caregiver and family into the program. The strategies we used was involvement in the session activities, encouraging participation in the question-answer sessions and discussions, carer appreciation sessions, and special sessions that focused on their needs. Our vision was to build a Parkinson's community at each support center. Education, therapy, and fun group activities facilitated the sharing of experiences and encouraged the development of emotional and psychological support for both people with Parkinson's and their families attending the center. And this is what we hope to achieve in Kenya.
So after initial conversations about the Indian model and the challenges that Kenyans faced with Parkinson's, Maria and I approached the Building Global Relations Working Group with the idea of replicating this model of care that Maria had developed in India to the Kenyan context. However, both being developing countries with limited finances, we knew that financial support towards the employment of facilitators and the development of resources would assist in the efficient implementation of the program. Eli suggested approaching Max Koslov from the Edmund J. Safra Foundation with a proposal, and we're extremely grateful to Max and the foundation for their encouragement and support in helping us take this first confident step of the project.
We held initial meetings that brought clarification on the roles and responsibilities of the two organizations, PDMDS India and APDF Kenya. The India team would be led by Maria and Shamila, and the Kenya team would be led by me and Tash. India would be responsible for the management of the project. This would include analyzing available resources in Kenya, designing and implementing training modules for the team, developing the sessions and resource materials, and monitoring and evaluation of the program. The Kenya team would be involved with identification of the personnel, selection of the venue, implementation and documentation of the program based on the requirements. The final project report will be written by both teams.
So to briefly outline the program, the duration of the program will be 1 year. This will include initial training of the facilitators, implementation of the multidisciplinary model, and documenting the program. The multidisciplinary model will be conducted through physical meetings over 10 months, held once a week or once in 15 days, for the duration of an hour and a half. Effectiveness will be assessed through an analysis of the implementation of the program and a comparison of pre and post qualitative and quantitative measures of perceived improvement of quality life.
The program will be implemented in the beautiful city of Mombasa, Kenya, and the facilitators to implement the program have already been identified. We held an initial meeting to explain the project and facilitators' involvement, identify their strengths in the field, design and development of resources and training models has also been initiated. Based on a provided script, introductory calls have already been made to existing members of the support group in Mombasa to obtain demographic details and levels of interest. Feedback from the calls is being documented. However, one challenge we currently face is the increasing incidence of COVID-19 cases in Kenya and restrictions on movement and gatherings. These may delay the face-to-face meetings with people with Parkinson's and their family members in Mombasa.
So we hope to evaluate the replication of the multidisciplinary model of care to the Kenyan context. The case study will analyze the strategies that worked, those that were not applicable, and those that needed adaptation and contextualization. The lessons learned from this case study on the model's applicability could be used as a global model to replicate across other low and middle income countries worldwide, where services that can significantly improve the lives of people living with Parkinson's and their families are unavailable, inaccessible, or unaffordable. So we'd love to hear your feedback and answer any questions you have about the project, and we'll now open the floor to you all for our Q&A session. So I think I'm going to hand over to Tammy now to start our Q&A moderation.
Thanks, Tash. I'm just waiting for them. Oh, here we go. We've flicked back over. Thank you. My technical hiccup. Congratulations, guys. You've taken this project and you've developed it so far already. It's so exciting, and I can't wait to see how it goes over the next year, to see, the results of how that does get replicated from the Indian context into the Kenyan context. So for all of you in the audience, please use this opportunity to touch base with our speakers. We've got Dr. Maria Barreto, Dr. Tash Fothergill-Misbah, and Helen Moithiga. Please post your comments and thoughts into the comments section. If we don't get to them today, it'll give our speakers a term of reference and they can come back to you. I'm going to start off with a question here for Helen from the Africa Parkinson's Disease Foundation. Helen, how accepting or welcoming do you think people with Parkinson's and their carers will be to the program in Kenya? And do you think they'll engage well?
Thank you, Tammy. Based on the initial scripted calls that have been done, the PD community in Mombasa is very excited about the program. You see, for a long time, the PD community in Kenya has had to deal with the challenge of lack of information and low access to healthcare and allied professionals. So this program is bridging that gap by bringing information closer to the community members. And of course, it's going to improve the quality of life through the education and the therapy. So yes, we expect our members to be very engaged and ready to do this. Thank you.
Thanks for that, Helen. Much appreciated. What kind of challenges do you think, Helen, you're going to see? What have you kind of troubleshooted already? What are the challenges you think you're going to come up across?
As I mentioned earlier, the current challenge we are facing is the increasing number of COVID-19 cases in Kenya. So what is happening is there's a lot of restriction about movement and also gatherings. And of course, as a team, we are also, we cannot start until these cases have gone down because we need to take care of our patients too. Another challenge that we expect is the poverty cases in Kenya. Why poverty is a challenge is because in some cases, most patients would want to be involved in this program, but may have difficulties attending sessions consistently due to lack of transportation. And as an organization, we are looking into strategic and innovative ways to keep the support group committed to the program and ensure that the attendees get to the sessions with little or no challenges or added burden. So another challenge that we have experienced in the past is the poor access to medication, because the Parkinson's community is more worried about access to the medication than access to the information. So we've had cases where people may not come for support group meetings because they think they may not be as important as getting like free medication. In the long term, access to funding is definitely a challenge. PD programs and neurology in general have not received adequate public funding or attention in the past. For this program to be replicated successfully in other parts of the country and the wider African continent, we will have to conquer this challenge of access to funding. Thank you, Tammy.
Thank you, Helen, for that. Much appreciated. Just looking at the comments now, I see we've got a comment here saying, if someone else wants to try to implement this in their community, we could always look at this as a possibility for a 2023 project. So it's really exciting. This is the first, but not the last. So please, if that's something that you're interested in, and good time to pop your name and contact details in the comments. It might be that you want to get involved in some other way leading up to perhaps that in the future. We are zooming through our time. I've got a question here for Tash. Tash, do you think there's going to be any challenges being able to find coordinators in Kenya based on the Indian experience? I do recall Helen saying that people have been identified. Any challenges, do you think, with drop-off? And if there are challenges, what you think they might be?
Thanks, Tammy. Yeah, so we have already identified 4 or 5 people. So they all had a prior interest in Parkinson's, so it kind of was a natural progression for them to be involved in this. So we had one person who runs currently the support group in Mombasa, a nurse, a dietitian, and a physiotherapist. So we've got quite a range of people at the moment, but like I say, they had a prior interest in Parkinson's already. So it might be difficult trying to sort of engage people, healthcare professionals, to do this because they don't really know about it, or it's not a thing that they see much in their clinics. The other way that we could engage people is through family networks, so people's family members and caregivers. And I know that's something that Maria has sort of tried to do in some more remote areas where they might not have access to therapists or nurses. So I guess it will be something that develops as we sort of see who joins and see who the family members who are participating are, and then try and engage them. But drop-off is certainly an issue, and it might be a challenge anywhere that you try and implement something like this. But I think it does help that if the people are sort of employed on the program, it will be more of an incentive for them to stay and work through it rather than on a voluntary basis. And I think that's where the funding is really important, is that we're trying to keep these people on to take charge and lead these programs for the duration of them, not just, you know, attend when and if they can, and because they're paid, I think, and I hope that that's what will happen.
Thanks, Tash. I can see we've got Ronnie Tadaro joining us on the virtual stage here, so we'll need to move to wrap up comments, so I'll just pass back to Tash.
Fabulous, thank you. I do have a contact slide to share with you all. So I know that maybe there were some questions in the chat that we haven't had a chance to answer, but we're really grateful to all your questions and comments. And please do contact us on any of our email addresses if we haven't answered your question, or if you have any other comments, or you'd like to do this somewhere else in the world. Obviously, the point of this multidisciplinary replicating this is that we do create some way of replicating it in other countries. So we look forward to keeping you all updated as the project progresses, and hopefully present our findings next year in Barcelona. Thank you.